A syndesmosis sprain is often called a high ankle sprain. Your proximal and distal tib-fib joints work together primarily at the ankle, but it's not just the joints that are going to be working in order to maintain that stability of the ankle. You have a syndesmosis that runs between the tibia and the fibula, but in addition to that syndesmosis, the stability or restraint is going to come from your anterior tib-fib ligament as well as your posterior tib-fib ligament, each of which are going to provide about 33% of that stability. Then you have your interosseous membrane providing about 22% and your transverse ligament at about 11%. Syndesmosis sprains are found in about 1 to 11% of all ankle injuries. Generally, the mechanism of injury for a syndesmosis sprain is a full closed kinetic chain issue where the forefoot is loaded with the heel off the ground and an external rotation on the lower leg. You may also see a forced dorsiflexion or hyperdorsiflexion occurring. Signs and symptoms include anterior lateral edema that's localized to the syndesmosis joint, point tenderness at the syndesmosis joint, and the person finds that it's very painful to walk. If you think about what is happening at the ankle joint, your tibia sits kind of on your talus with your fibula a little bit off to the side. So every time you take a step, that tibia is being pushed into the talus. And so it's going to be very painful because that pressure that is placed there causes a spreading of the joint itself that has been damaged. And so you're putting stress and getting an opening in that joint. Range of motion is generally going to consist of decreased dorsiflexion. During closed pack position, you get a diastasis, which is also known as a widening, as I just described. There are several special tests that you can use for a syndesmosis sprain. The first is the Kliger's external rotation test. This is done by stabilizing the tibia, and then you force the foot into dorsiflexion, which really pushes that talus up into the tibia, and then you externally rotate the foot. You can do squeeze or compression tests. It won't hurt to put the compression, but when you release, people will complain of pain because you're getting a widening of that syndesmosis. And then you have a fibular translation test. You can do this test, and you're basically just trying to see if the ATFL or the PTFL has been damaged. Manual muscle tests are going to be for your perineals, as well as for your Achilles tendon. For functional tests, you'll find that straight ahead running is okay, but lateral movements or cutting side to side tends to be dysfunctional. It's very painful to plant and cut in each direction. Diagnosis is going to be through an x-ray, and you want this x-ray to actually be a functional x-ray, because if you just use a passive non-weight bearing x-ray, you can't see the diastasis occurring. Additionally, in that x-ray, you're going to use it to rule out a fracture. Unfortunately, syndesmosis sprains are very difficult to treat. If you have a grade 1 or 2, it could be anywhere from 6 to 10 weeks for a full return to play. The return to play itself could be 2 times as long as a third-degree ankle sprain. For a grade 3 syndesmosis sprain, this is going to require surgery. There's going to have to be an internal screw fixation to prevent the widening of the syndesmosis.